Is everyone ready? Good, kind of.
Yeah.
All right. So this morning we're going to talk about several procedures that are done on the venous system within the ultrasound labs. So the first being a ultrasound exam called a vein mapping. So a vein mapping is specifically used to evaluate the superficial veins of the extremities for use in either hemodialysis grafts or for arterial bypass grafts. So vein mappings, we evaluate superficial veins of the extremities. And this is done as pre-surgical planning. And they're done for patients that would potentially need to go on dialysis. So we do a vein mapping to evaluate if to create something called an AVF. This is arterial venous fistula. Which is used for hemodialysis. We also do a vein mapping for arterial bypass grafts. So this is for patients that have peripheral arterial disease. So basically with the arterial bypass grafts, we're trying to bypass any stenosis or occlusions within the artery and trying to get blood flow down to the distal extremities. And the reason we like to use native vessels as opposed to like a man-made synthetic material for bypass grafts is because there's a less likelihood of rejection. So it's our native vessel. The body recognizes it as, something that should belong within us, as opposed to putting like a man-made material to create these conduits. The body may try to attack that and could lead to failure of the graft. So if whenever possible, surgeons like to use, your native vessels. So with vein mapping, we like to use a high frequency probe. Between 7 and 14 megahertz. So for me, I really like that hockey stick probe. That's the one I go to. This is going to allow you to get greater detail to really get a good, accurate measurement of the vessels. And you also want to make sure that you're scanning the patient in the position that they're going to be in the OR. So the reason for this is you don't want to be doing a lower extremity vein mapping and have the patient's legs hanging low and get a falsely elevated size of those vessels just because blood flow is now going down. And then when they get to the OR and they have them nice and flat and level, and then the surgeon's like, well, I thought these veins were like much bigger, or might make it much harder for them to actually harvest these vessels. The first thing we're going to do when we start this study is we're actually going to evaluate the deep system. So we're going to do our normal lower extremity or upper extremity DVT study. So basically what we're doing now is just we're rolling out DVT. So then once we've ruled out DVT, we're going to move to the superficial veins. And we're going to evaluate patency. And you do that by, by showing compression.
Dan, you said that's superficial veins, right?
Yeah, so now, so these are the superficial veins. So first we do a DVT study, just to evaluate the deep system to rule out DVT, and then we move to superficial veins. So evaluate superficial. Superficial veins. So we want to show compression as well as color filling. So then we measure the diameter of the vessel. So I do an anterior to posterior measurement. For me, anterior to posterior is going to be your most accurate measurement. And I do an outer to outer measurement. So an acceptable diameter would be a diameter greater than or equal to 3 millimeters.
Did you say an acceptable one?
Yeah, so we want a diameter, because if the vein's too small, doctors can't use it. So we want to look for a diameter that's greater than or equal to 3 millimeters. Like you saw when we were scanning the arm, some of those veins are so super tiny and so super small. If they're just too small, the doctors they wouldn't be useful. You know, those channels become too small for their intended purposes. Especially like if we're creating a dialysis fistula, with those, we need a very large flow volume getting through for the dialysis machine to operate properly. So if the vessels are just too small, they're not going to create that flow volume that's needed. And the same thing too, if we're using it for bypass for the arteries in the legs. If these vessels now are, you know, when we harvest them, remove them and turn them into arteries, essentially, if those vessels are too small, they're not going to provide adequate perfusion down to the foot or down to the hands. And if they're small as well, they run a higher risk too of becoming calcified in the long run. And the other thing you're also going to measure is the depth from the surface of the skin to the vessel. So you'll have your vessel in the middle of the screen. You'll take your measurement. Oops, sorry. Do outer to outer. And then you're also going to take a measurement. So if you have your ultrasound image, the top of your screen is the surface of your skin. You're going to drop a caliper down and measure that distance from the surface of the skin to the vessel. Just so the doctors get an idea, you know, how deep they are, how far they have to go in. It's all part of, you know, the pre-surgical planning. So in your textbook, you're going to see pictures of people drawing with markers on legs. I've never had to do that. I'll be honest. I've done, hundreds of vein mappings, and like we just document with the ultrasound machine, like the vessel size, and we're taking images, at different levels, kind of giving like a representative image. And we're with our ultrasound machine, we're able to we document like where there are tributaries and varicosities coming off. But for sake of the registry and depending on like where you go, if maybe you wind up in like a vascular surgeon's office, they may actually have you drawing. The protocol for that is you're in a transverse orientation. And you follow the course of the vessel. And every 2 centimeters, you make a mark. And you also mark location of perforators. And tributaries. And then you could use a pen to kind of connect all those dots as you're running along the course of the vessel after you're done. So what are the 2 superficial veins in the legs that we're going to evaluate, that we're going to look at for vein mapping?
The great saphenous and the small saphenous.
Good. I'm just going to put lower extremity vein mapping, VM. So we have GSV and LSV, or small. So with the GSV, we're going to do 3 measurements in the thigh. Usually, prox thigh, mid thigh, distal thigh. In Dr. Pellerito's lab, he also does a measurement at the level of the knee. And then he does 3 measurements in the calf. And it's labeled prox calf, mid calf, distal calf. Some labs may not have that knee measurement. So at least the minimum, you're going to have 3 in the thigh and 3 in the calf.
Hey, Dan, can you move the camera over just a little bit? Thank you.
The greater softness vein, that is the primary choice. So if we're able to do the greater softness first and harvest that's going to be the surgeon's primary choice. If the greater softness is no good, if there's thrombus within it, if the vessel size is too small, then we'll also image the lesser softness vein. We'll have these images as well. So with lesser softness, we do an image at junction with popliteal. And then a prox calf, mid calf, and distal calf. I'm actually just going to rewind a little bit. I was just thinking, I forgot to mention just one very important thing for vein mapping for reasons. For coronary artery bypass. So you might see the acronym CABBAGE. That's coronary artery bypass graft. with this one, you're evaluating GSV and small saphenous vein. So upper extremity. So the upper extremity vein mappings, these are the ones that we're going to typically do for patients that require hemodialysis access or an AV fistula. Patients that require hemodialysis access. So with this, we're evaluating the cephalic and the basilic veins. So with the upper extremity mapping, vessel depth is an important criteria. Oh, vessel, I didn't right. Vessel depth. And the reason for that is because when we create the AV fistula, that vessel is gonna have to be accessed over and over for dialysis when they put them on the dialysis machine. So if the vessel is very deep and hard to access, it makes dialysis more challenging. So if a patient has a very large arm and the vessels are very deep, the surgeons may elect to go for a graft, like one of those man-made conduits or channels, and place that more superficial to make dialysis easier. I'm just going to put due to repeated access during dialysis. So for cephalic vein, we're going to do, again, 3 measurements in the upper arm. Measurement at the antecubital fossa. And 3 measurements in the forearm. So again, so we do proximate distal upper arm, antecubital fossa, and then proximate distal forearm.
I have a quick question.
Sure.
It kind of applies, I guess, to lower and lower and upper. Like how prox do you go for like the cephalic? Like
So cephalic vein, I'll come, pretty high up, like just
Okay.
below, like a little bit below the shoulder,
Mhm.
and then proximate distal.
And what about like the great saphenous? Like how prox?
Prox, so I'll be just below the level of the junction, so kind of in the groin area. That'll be like my prox.
Okay.
So same thing for the basilic vein. We're going to do 3 measurements in the upper arm, an antecubital measurement, and then 3 measurements in the forearm. Forearm. Fossa. Measure. So this is why vein mappings can really take a long time in the lab. Especially, you see techs shudder like, vein mapping, they always seem to be like some of the last things on the list. Because, you have to do a full DVT study, make sure there's no DVT, and then you go back and check all the superficial veins, make sure there's no thrombus or clot in the superficial veins, show they're patent, and measure them. So it's tedious, it's time consuming. I'm just going to change this because there is another mapping exam. I'm just going to put vessel mapping here now because this is actually an artery. But Lily had it on the PowerPoints for this week. This is something called a modified Allen's test. I think she kind of went over this last semester with the arterial stuff, right? Kind of, sort of. All right. This is called a modified Allen's test. So what this is this is an evaluation of the radial artery. And the palmar arches. And we do this for potential harvest of radial artery. For coronary bypass. So this is typically something that we'll do, you know, if the veins in the legs don't look good, the doctors will go like, all right, what's next? What are our options we have? So this is another potential option that the doctors could have for coronary bypass, this harvesting of the radial artery. So we're going to measure the diameter. Radial artery. We're going to do a prox, mid, distal measurement. We're going to assess for calcifications and stenosis. So if that artery is calcified, if there's blockages, it's no good. So this is done with color and spectral Doppler. So we're going to get waveforms. We're going to measure velocities. Color and spectral Doppler. Velocities. We're going to do this at each segment, approximate distal. So I make sure I gave him 5 fingers. All right, so then we're going to move on to the second part of the exam for an Allen's test. So the radial ulnar is running down along the thumb aspect of it. Then you have your deep palmar arch. Ulnar artery running along the pinky aspect. Superficial palmar arch. So there is a connection between the 2 palmar arches. And that's what we're evaluating for. We want to make sure that it's a complete palmar arch. So when we start the second part of the exam, the first thing we're going to do is we're going to put the transducer on the distal portion of the radial artery, like kind of just above, below the level of the wrist right there. Place transducer. Distal radial artery. So I'm just going to put just below wrist. Then we're going to do a Doppler waveform. So with this portion, you want to make sure that your scales are set up properly. You don't want a waveform that's too small, because we're going to be now looking for changes in the amplitude or size of that wave. So you want to make sure your scale is set up properly, to optimize your waveform image. Now we're going to compress the ulnar artery. So this is the type of exam that you wish you had a third hand, because you're trying to, stay on the vessel, compress the other artery, operate the machine all at the same time. It's challenging. All right, so we have our probe on the radial artery. We're going to compress this ulnar artery. So now what we're going to look for is an increase in amplitude. So if this is the height of our amplitude for our baseline, when we do compression, we should see an increase in flow or an increase in velocity or amplitude of that waveform. And the reason for this is now that we've occluded this artery, in order for the rest of the digits to fill, we're going to now increase blood flow in that radial artery to kind of feed that the superficial palmar arch and bring blood flow to the rest of the digits as well. So I'm going to look for increase and amplitude of a waveform. Does that kind of make sense to everyone? Kind of, sort of? Yeah.
Wait.
So this might be, oh, sorry. Go
No,
ahead.
no stupid questions.
I just want to make sure. So like your transducer's on the radial artery, and then you compress the ulnar artery,
artery.
and the waveform in the radial artery goes.
Artery
Okay.
goes- Yes. Yep. Correct.
So then with that, when that does happen, you said that's a
That's a good
complete-
sign. That's what we want to see. That proves to us that this arch is complete, that the pathways are all open. So those connections between the two arches,
Mhm.
they're open, those little connections.
So
And
that
that's
would
what
be
flow is getting
considered,
through.
so that would be a complete palmar arch, right?
Complete palmar arch.
Okay.
Yeah.
Okay, perfect. Thank you.
Yeah, that's a good term. We'll put that, complete palmar arch. So now we also have to do kind of the same thing with the ulnar artery, just to, verify that it truly is a complete palmar arch, that both of those connections are, open. So we kind of reverse the process. And we're now placing the transducer on the ulnar artery and compressing the radial artery, and we should see the same result, get an increase in the amplitude of the waveform. And we can just put over here, reverse vessels and compression. Doppler, ulnar. Compress radial. Radial. So if it's a complete arch, we will have increase in amplitude. Of waveform.
Dan, can you move the screen over a little so we
Yeah,
can see
yeah.
that side? Thanks.
If there wasn't a complete arch, would you just see no change?
Correct, yes. Yep.
Okay.
Okay. All right, so if no change in amplitude, sorry, be an incomplete palmar arch. So the reason we do this is because we're not going to take this artery out. We want to make sure that that ulnar artery is sufficient enough to supply the digits. We don't want to remove this artery and all of a sudden the guy's fingers start turning blue and then we have to start amputating, digits. So this test is really important for evaluating that palmar arch. With the vascular lab I worked at, they actually added a third component onto the test. And this might just get you to think a little bit, about what's going on. So in my lab, we would Doppler radial artery. And then compress the radial artery above the level of the transducer. Anyone have any ideas or guesses what might happen?
Amplitude would decrease.
It's a good guess. So what's going to happen actually is you're going to wind up with slight reversal of flow within that radial artery. So this is how you can also prove that there's a complete palmar arch. So the reason that happens now is we're Dopplering here, we're occluding here, so there's no blood flow getting down to that segment of the palmar arch. So the hand is now actually going to steal blood from that radial artery. So you're going to get a slow reversal of flow because it's now stealing blood from that radial artery, going back the other direction. So if you're doing this and you compress the radial artery and you just get no waveform anymore, so you got your waveform and then it's just flat, you have no more waveform, that's a sign of an incomplete palmar arch if you're using that method. So it would just be just flat, nothing. Question.
Could you explain that logic again in the reverse flow?
Sure, sure. So we have our probe on the distal radial artery. We're compressing it, so there's no blood flow getting into there. So the reason we get reversal of flow is because the segment of the artery that we're Dopplering is now getting fed by this palmar arch. So the blood flow is now coming back around this way to kind of feed the deep palmar arch. So we got a connection. It's usually like around there. So blood flow is coming in this way, coming in that way, and then going retrograde to kind of feed these vessels because now they're not getting blood flow. So the muscles of the hand, it's kind of like that way of thinking. Like I use this example that like the organs of the body are kind of like a straw that want blood. So they're sucking on the vein, sucking on the arteries, trying to get that blood. So the muscles of the hand are requiring blood flow and they're not getting it from the radial artery. They're going to tap into that superficial palmar arch that's fed by the ulnar artery. And you're going to see a reversal of flow because it's now stealing. It's almost like a steal syndrome that you're creating. This is incomplete. Another thing you also want is a radial artery diameter of greater than 2 millimeters. All right, so we're just going to take like maybe like a 10-minute break and then we'll get into like venous insufficiency and reflux. All right. That's the life of me. So what happened to the snow this morning? I woke up expecting a little snow. Oh,
I'm happy without it.
yeah.
I mean, it did snow down here. I mean, it wasn't a lot of
Oh,
snow.
it did?
Yeah. I'm in Maryland in
Oh,
like
okay.
Cecil County, but we got some snow. It
Okay.
not much, obviously, but
Yeah, there was like nothing when I woke up. It was like
Oh,
almost
yeah.
dry. I was like, oh, all right,
Snow days are only fun when you don't have anything to do.
true.
That's just my opinion, though.
Any questions so far about anything or pretty straightforward?
I have a question.
Sure.
What happens to, let's say, great saphenous vein when it's harvested? I believe it's only a certain length that is harvested. What has happened to the rest of it?
What happens to the rest of it?
Mhm.
So they'll,
Is it attached to another vessel?
no, it's not
No.
attached. Typically they'll ligate like near the junction. So you may see like if you're doing your Doppler, like a small little piece of it, but they'll typically ligate the vessel and then harvest the section that they need. And then over time, it kind of just shrivels up like the part that they don't use, like that's below where they ligated. So it's essentially like disappears over time.
Mhm.
So they'll tie off high up, they'll harvest the part that they need, and the remainder that they don't kind of shrivels up and gets small.
And then the body gets rid of it by
Yeah,
itself?
it's just kind of there. You don't even really see it on ultrasound. Yeah.
Hmm. And the same with the radial artery?
Radial artery, yeah. I mean, yeah, so they'll ligate and then harvest the section that they need. You know what? I'm gonna look into that for you with the radial artery because I'm not 100% sure, but I'm gonna look into that for you.
Okay.
I wonder if they would like try and connect to the ulnar.
Mhm.
I'll have to find out for you.
Okay.
'Cause I'm not 100% sure about the radial artery, to be honest. I know about the vein, yes, but like I'm not 100% sure. I'll find out. It's a good question, though.
So Dan, what we're about to do, are we about to like learn about like chronic venous insufficiency? Is that what this is?
Yeah, so this is testing for venous insufficiency, like different
Okay,
exams that we do. I mean, the main thing, is we use ultrasound now, but there are there's another method that's mentioned like in the vascular textbooks that typically we don't use anymore just because ultrasound is so accurate and
Mhm.
it's easier. Kim back? No, not yet. All right, so I'm gonna start. So venous insufficiency, that's the medical term that we give to describe incompetent valves. I can never spell. Valves. So these are valves that allow bidirectional flow. So it can be seen on ultrasound. Use when you do color Doppler, you can see the vessel go from blue to red. Basically what I'm saying is, like, you might be doing a venous study, say you're doing a DVT study and you're Dopplering. You'll notice, like your blood flow is blue, and then you make that a momentary moment, like when the blood flow turns to red and then goes back to blue. So that's a good indication that there's reflux in the veins when you're Dopplering, and you see it kind of alternating between blue and red. So that's just kind of like a subjective way to be like, all right, there's most likely, or there is incompetent valves and venous insufficiency. But then we have to kind of go back and kind of quantify it, and try and pinpoint exactly which vessels demonstrate insufficiency and the severity of it. So some causes of insufficiency, you could have congenital. So you can actually have veins that are avalvular. Meaning that there are no valves in the veins. Oh, no valves. Patient could have something called an AVM, or an arterial venous malformation. So some other causes that are not congenital could be patients that have congestive heart failure, CHF. And pulmonary hypertension. So with these two conditions, this can increase venous pressure. So also have age. So the older we get, the weaker our valves get, and the more likely to develop incompetent valves. And probably one of the most important ones is damage to the valve as a result of DVT or superficial thrombophlebitis. That superficial thrombophlebitis, that's clot within the superficial veins. That'd be the greater saphenous, lesser saphenous, cephalic, basilic. So after patients have had a DVT or superficial thrombophlebitis, those clots, as they resolve, they can cause, or they typically do cause damage to the valves. So today we use ultrasound to really diagnose venous insufficiency, and it's utilized, to really appreciate how much reflux is going on and which vessels are involved. Patient position. So we want to lower the legs. To increase hydrostatic pressure. So we want to simulate, real life conditions as much as we can. We want to simulate what's going on when someone's standing, because we're not lying in bed all the time. We're up, we're active, we're walking around. So that's when the legs are going to swell, because we are increasing that hydrostatic pressure and putting more pressure on those valves. So some labs will actually do something called a standing reflux study. The patients are actually standing up and we're trying to Doppler and measure the reflux in a standing position. But if they're not able to stand, we try and just lower the foot of the bed, kind of get them at an angle as best we can, whatever's comfortable for the patient. So the next thing we're going to do is we're going to Doppler the vein. We got our nice venous waveform below the baseline. And then we have two choices. We can either have the patient Valsalva or we can do proximal compression. You guys all know what Valsalva is? Yes? Yeah? Okay. I like to use the Valsalva method, especially if I'm proximal in the thigh, like imaging the greater saphenous, near the junction. Because it's really hard to kind of do proximal compression and pushing on the lower pelvic for those vessels. So when we have the patient Valsalva or do proximal compression, if it's a normal healthy vein, we should have absence of flow. We should be able to stop flow. And the venous flow would just kind of return to baseline, and we won't visualize any flow there. So flow should stop. We can put Valsalva. And this would be release. This would be normal. But if the patient has incompetent valves, when they Valsalva, you will get now a reversal of flow. And then when they release, return back to normal flow direction. So we can visualize that reversal flow when the flow goes above that baseline. So this is now reflux. So the way we quantify, the severity of the reflux is you'll notice on the bottom of the screen here, you'll have time markers that delineate seconds. So then we look as to when they're valsalving, how long that reflux lasts for. So reflux time greater than half a second is considered significant. Meaning that it's an issue. Anything greater than 1 second is considered severe. It's an issue. So if it's less than half a second, there is a little bit of reflux, but it's not really an issue. If it's over half a second, then it can be considered an issue. If it's greater than 1 second, they consider it severe reflux. Um, So with this study, we evaluate the deep veins, superficial veins, and perforators. Those are those connections between the deep and the superficial systems. And we also evaluate any tributaries off of these vessels. Any tributaries or branches off these vessels. So the main vessels. if we have deep vein venous insufficiency, there is no medical slash surgical intervention that can be done. So basically that all we can do for these patients is prescribe compression stockings. So we can do compression therapy. Compression. Compression stockings. A lot of times I'll get patients, that have suffering from venous insufficiency, and they've been to the doctors, and they're like, the doctor said, there's nothing I can really do about it. He just told me to wear compression stockings. I'll always ask them, were you fitted properly for these stockings? Did you get a prescription for them? Did you go to some place that actually fitted you for these stockings? Because a lot of times these elderly patients, they'll get the prescription, they'll go buy whatever they think, or they'll wrap their legs themselves, thinking they're doing the same thing. But it's very important that they're properly fitted for them, because otherwise they're not really doing anything. If they're too loose, it's not doing any good. If they're too tight, you could be doing damage, you could be an issue as well. So it's just an important consideration. So I'll always ask them, like, were you properly fitted for them? I'm like, oh no, I didn't know that was a thing, so it's just all part of looking after that patient.
Why can't you do any medical or surgical intervention for deep venous insufficiency?
Because the interventions that you do are basically ligating the veins, or vein stripping. They used to strip the veins, actually physically remove them. Now they do process where they may inject saline to kind of seal it off or close it off. And you can't do that for the deep veins. These are the main pathways, bringing blood back up to the heart. So these pathways cannot be blocked. So yeah, so we can't do any sort of ablation or medical procedures to prevent the insufficiency in the deep veins. These channels need to stay open. So when those valves start to leak, that's unfortunately, it is what it is. So with superficial insufficiency, the main treatment now is a procedure called a venous ablation. So with this, it's a small catheter that's inserted into the vein. And the tip of the catheter it has a high frequency I want to say transducer. It's like a high frequency. So the high frequency electrode. And what it does is it delivers energy into the vessel that actually heats the blood flow and creates a clot. So which delivers heat to clot the vessel. And damage the walls. Damage vessel walls. So basically the point of this is we're heating up that vessel, we're stopping the blood flow, And we're kind of disintegrating and destroying those vessel walls. And eventually over time, where the vessel was is going to kind of break down, like the vessel that was there is going to shrivel up, and it's eventually going to disappear. Like any clots that were there will get reabsorbed. And this is a way to kind of alleviate pressure. Vessel destroyed. I mean, the process is a little more complicated than that. Like they administer, like also with ultrasound guidance, like a needle to like some fluid around the vessel to kind of create a buffer around the vessel. So they're not actually destroying the tissue and they're just focusing on the vessel. I think some of Lily's PowerPoints go a little more into detail on the actual procedure. But I mean, you know, in terms of registry wise, the main takeaway is that we can correct superficial insufficiency, you know, deep insufficiency there isn't much we can do. And then the main procedure, you know, is a venous ablation where we actually, you know, destroy that vessel that's causing the reflux. So I'm just going to play a quick video. There is another exam that we can do to evaluate for insufficiency that was a little more common before ultrasounds really took off for evaluating insufficiency. So I'm just going to quickly share and play this. So this is utilizing photosensors like a PPG sensor.
The Ames Level is a two-channel DPPG LRR device that has two infrared sensors to perform venous function measurements. This facilitates fast diagnosis of venous valve incompetence. To start operating the device, simply plug it into the venous button or computer. The measurement is made on the seated patient. The patient should sit down for at least 2 minutes in order to achieve a stable circulatory situation. The sensors are ideally placed 10 cm proximal to the median iris with double-sided adjacent rings. Make sure that the measuring point is free of excessive hair increase. The red sensor with the inscription R is placed on the right leg. The blue sensor with the inscription L on the left leg. The sensor cable should be directed downwards. The angle between thigh and lower leg should be about 110 degrees, so the leg should be slightly stretched forward. After the calibration process is completed, the recording of the sensor signal starts automatically. The patient should now operate his muscle pump with 8 powerful dorsal reflections. These pumping pulmonary movements are optically displayed in the lower right of the screen and accompanied by acoustic signals. In the process, venous blood is pumped out of the venous system. This is followed by a resting period until the end of the measurement, during which the venous recovery is recorded. Page level automatically calculates venous pump volume V0, venous refill time T0, and half refill time T50. Additional sensors on both probes detect and compare the skin temperature of the patient during the measurement. The results are displayed in a clear color scale. Optionally, another measurement can now be recorded with a tourniquet cuff attached.
All right. So that exam that they were performing is, there we go. It's called a venous photoplethysmography exam. So what this does is it measures venous refill time. So we're going to abbreviate that VRT, venous refill time. And we use that venous refill time to detect the presence of insufficiency. So we have the patient seated. And we place PPG sensor five to 10 centimeters above the medial malleolus. Then we're going to have patient will dorsiflex the foot. Usually 5 times should be sufficient. This is in order to empty the blood from the calf, the venous blood, empty the, in order to empty venous blood. From the calf. And we measure the time for venous blood to return for refill. Measure, measure time, sorry. Measure time. Venous blood. To refill. So what that's going to look like is we're going to have a chart. And we're going to have our normal venous waveform. And then we're going to have the patient start flexing their calf. And we're going to see little spikes as every time they dorsiflex, blood is going to be pumped out of that calf. And then we're going to see a slow refill back up to that baseline. This is time. So then what we're measuring now is the time it takes from when they stop pumping to when we return back to that baseline. That's going to give us our VRT, vessel refill time. So a normal VRT will be greater than 20 seconds. So we have the patient pump their calf, we empty the blood from the calf. There should be a nice slow progression back up of vessel filling. That's in the normal healthy leg. So for a normal VRT, you have a gradual, slow, so in patients that have insufficiency, we're going to get a faster refill in time. In those cases, VRT is going to be less than 20 seconds. So in those cases, we're going to have a much sharper slope to the line. It's going to be a much faster refill, and the time is going to be much shorter. So the reason for this is because we now have blood flow leaking back into the veins that's filling the veins in the calf from insufficiency, as opposed to just being filled naturally by the arteries passing through the capillary beds. So the normal process of the veins filling back up through the capillary bed is a slower process, or much slower process than us getting all of a sudden, like they pump that blood out, then all of a sudden we're getting a rush back because those valves are incompetent or leaking. So that's the whole premise of this test, this exam. So if we do this exam initially and we have a VRT that's greater than 20 seconds, that's normal, it's good. The patient has no reflux. But if we see a VRT that's less than 20 seconds, we then place a tourniquet just above the knee. And this is to remove the influence of the superficial veins. Namely the GSV. So it doesn't necessarily have to be a tourniquet. You can also use a pressure cuff. So we're going to place that tourniquet just above the knee, and we're going to basically repeat that exam that we just did and measure the venous refill time. So now if our VRT is greater than 20 seconds. We can assume that the patient has insufficiency in the greater saphenous vein. So we did the test initially. We saw that they had a low VRT, meaning less than 20 seconds. So that raised the flag, like, all right, this patient has insufficiency. We placed a tourniquet above the knee. We cut off the circulation from the greater saphenous vein. And now we got a VRT that is greater than 20 seconds. So that's normal. So we can effectively deduce that the insufficiency, though, is causing that decreased filling time, was the greater saphenous vein. So if we still have a VRT, that is less than 20 seconds, it could either mean we have insufficiency in deep veins, or a small saphenous vein. So if we're still getting fast filling, even after we place the tourniquet, it could be an indication that we have insufficiency in the deep veins or the small saphenous vein. So then we have to take this step, examine another step, a step further. We'll then place a tourniquet just below the knee. So now this will remove the influence of the superficial veins, both the greater saphenous and the small saphenous vein. So if we now put the tourniquet below the knee and we get a normal VRT, we can assume that it was insufficiency in that lesser saphenous vein. And if we're getting a fast VRT, less than 20 seconds, and we've put a tourniquet on both above and below the knees, then we can assume that the insufficiency is just the deep veins. So insufficiency in deep veins. Tourniquet on both above and below the knee. Well, I'm going to put with tourniquet both above and below knee. Does anyone have any questions about this? Uh,
And is this test still performed in hospitals?
Not really. I've saw a couple early on when I started, but it's not common. No.
Probably it's time consuming compared to
Yeah, it is. I mean, 'cause
ultrasound.
you can go right to ultrasound and you know exactly, which valves, where in the leg, you're developing insufficiency. You can really ascertain how severe it is, like, it's just a much easier thing to do with ultrasound. You get much more information and a better appreciation of it. Like with this, I don't know exactly where along the greater saphenous or where along, the lesser saphenous, I could have my insufficiency or which deep veins, like it's just kind of a general thing. But unfortunately, it is part of the registry still. All right, so that pretty much does it for today. Does anyone have any questions about anything so far? No?
Not that I can think of right now.
All right. Well, let me know.
Thank you.
You're welcome. Have a good day, everyone.
Thank
You
you.
too.
Thank you. You too.